So bipolar just means that they're going from high highs to low lows. Okay. What you guys are talking about where they hate you, they love you, that's more of personality disorders.
Oh, okay.
Okay. Bipolar goes from like way, way, way up, way, way, way down. So they go from mania to depression.
Okay.
Mania to depression. That's why it's called bi, which means
two.
two. They're in two different poles, right? They're either on cloud nine euphoria or they're so depressed they can't get out of bed. Okay. Now, when they go in the high, yes, of course, you'll see some erratic behaviors. Okay. But their behaviors are more like inappropriate behaviors that are like socially not really acceptable. And I'll give y'all some examples as we go along.
Okay.
But let's kind of talk about what the mania and the depression looks like. Okay. So this is considered a mood disorder. So if you see on an exam a mood disorder, that's what this is. Okay. And then they alternate between mania, depression, and it may go rapidly, it may go slowly. They may have months of depression, then months of mania. Everybody's a little bit different, and we'll talk about, they do categorize those, so we'll talk about those next, bipolar I, bipolar II, kind of how quickly they go through mania and depression. All right, so let's start out with what mania looks like. All right, so just overall, before we go into the symptoms, they love being in mania. It feels very good because like you just feel like you have unlimited energy. You're moving all the time. You get so much done. You don't need very much sleep, right? You don't need very much to eat. And you have these, like pleasure-seeking behaviors. Some people overshop and they will spend their entire savings account during mania, okay? Or they'll spend their kids' college fund during mania. And they shop and they do all these things, but they get the high from buying, not from wearing. So you may find a closet full of unopened things because it's the shopping part. We know shopping makes us feel good, you know, and it's kind of therapy, okay? So some people, instead of shopping addiction, they get sex addiction, okay? Some people will take drugs when they're up in mania, but they are feeling very good and they don't like to come out of mania, which is why medication compliance is such a big deal with bipolar. Because once they get on their meds, they know they have to come down and it doesn't feel good, okay? Because you don't really have much social awareness when you're in mania, so you say whatever you want. That's what I'm saying was why it's like socially awkward. Not like socially awkward, like I don't know how to talk to you. Like they'll walk into a room and be like, why are you here? I told you I don't like you. You know, and they will have outbursts whenever it's not appropriate. They don't care, right?
You don't control when you get off of mania, though. It just kind of happens.
It happens,
okay.
Right? And they don't control when they go into it either.
Okay.
So mania is an elevated mood. Now they can be real irritable when you try to pull them down. Like if you're like, hey, you know, why don't you let me be me? This is me, you know? And so they can get really irritable and really annoyed. Spending sprees, increased sex drive, and everybody kind of has their own thing that they pleasure seek with, okay? Now it can get so bad in mania where they can go into hallucinations and delusions. What is the difference between a hallucination and a delusion? What's a delusion?
You believe something.
You believe something that may not necessarily be true, whereas a hallucination is you see, feel, touch, smell. One of your senses is activated with something that isn't true or isn't there, okay? The delusions are usually accusatory delusions, so they're usually accusing somebody of doing something, okay? You're trying to make me take my medicines. You don't even like me like this. And they accuse people of a lot of things because it's breaking up their high. Okay. They don't need to sleep. They have endless energy. Think of it like hyperthyroidism on, okay. They are just moving. Lack social awareness. So they will say anything at any time. Okay. When we grew up in the church, like we lived at church, and there was a lady that had bipolar. And she apparently was in mania. We were having this big church meeting, and you know, the church meetings, everybody's quiet. We're listening to the business, blah, blah, blah. And then out of nowhere, she gets up and she stands up and she's like, I don't know why I even come to this church. I don't like it here. You're a whole bunch of hypocrites. And then she ran out of the church and everybody was like,
okay, anyways.
So we're going to take an offering, you know. So that's what it means by lack social awareness. Like they don't get what's appropriate, what's inappropriate in certain situations. They're going to talk really, really rapid, and they have super risky behavior because they don't see any problem. When you're that high and you're that like up, you're like, oh, this is fun and nothing can harm me at this point. Okay. They feel very powerful, very euphoric. I would not want to come out of that either. Right? All right. So let's look at what we're going to assess. So if you're assessing somebody in mania, okay, you're going to first look at their affect. What's an affect? Kind of, but like also like just sort of what their behavior is looking like. Like, do you look, you know, fidgety and agitated? Do you look pissed? But a lot of times they are agitated looking, or they look euphoric or animated. What is animated? Oh yeah, they're just making a ton of faces. No, they're so excited and blah, 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 right? Labile or expansive. So those are, expansive means like bigger, obviously. Labile is kind of here and there. Okay. Now there are different types of mania. So when they're in mania, you can go stage 1, stage 2, stage 3. Stage 1 is hypomania. So that means a low level of mania. They probably won't be hospitalized for that, right? You could be outside the hospital for that. Okay.
Okay.
Okay, that was weird. Okay. They're just up. You may not even notice if somebody's in mania unless you know them very well. So increased motor activity. They're just kind of excited. They're kind of distracted. They kind of talk like you have ADHD. Oh, look, a bird. Okay. Whereas stage 2 in acute mania, you can tell that they have that. They may not necessarily have to be hospitalized if they're not losing weight or anything like that. But you can tell like.
But these can last like days or weeks.
Days, weeks, months.
Oh, wow.
Yeah. They can have a flight of ideas. What's a flight of ideas?
Oh, I want to do this. I want to do this. I want to do that.
Yes, things are going, and then they're kind of connecting things together. But like, oh, hey, have you get your hair done lately? Oh, hey, what about keto? And you just keep. Have you talked to people like this before? They may no.
I haven't met anyone with like any use disorder.
Oh, and it may not even be mania, but have you ever just like talked to someone who's like, "Dang, girl, you on something?"
Oh, yeah,
you know what I mean? Like they're just they talk. They may have increased sexual activity, maybe not be seeking like prostitutes, but they're just like, hey, let's go to the bar tonight, blah, 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 right? They have insomnia because they have so much energy, they cannot settle their body down in order to go to sleep. And then you've got stage 3, which is delirious mania. They have to be hospitalized for this because this is, now they're so up and their flights are going so fast, it scares them. So they get like panic level anxiety. They have not slept in days, literally days. And they have so much excess activity. They may come in dehydrated, malnourished. They cannot settle their body down. And we have to hospitalize them at that point because now we're looking at medical issues.
Oh, okay.
Right? Okay. As far as just, I'm going to do brief nursing care because I'm going to talk much more in detail about mania in a bit. Number 1, if they ever have on an exam, what's the first thing you do for a patient? You will always pick assess yourself. Okay, what are you assessing yourself for?
Can I deal with this? Am I okay?
Yes, am I stable enough to be able to deal with this? And some of these disorders, like bipolar is probably not one of them, but some of these personality disorders, once you get to those, they can be very difficult to deal with. Some people can trigger things in you, like if one of the patients, like let's say she's in mania and she looks like my mom. I may not be able to care adequately for her, right? Because I may just be projecting my mom on her. So if you get triggered by someone, meaning they look like somebody or and you don't feel like you can provide good care for that person, and it can go the opposite way too. Like I loved my grandmother with every fiber of my being. If I had a patient in the hospital that looked like her, I would treat better than any other patient. So if I feel like I cannot be objective, then I need to request a different assignment. Okay, because you have to treat these patients objectively. So that would be assessing yourself first. The second thing you do when someone's in mania is start to develop rapport. What's rapport?
I like a relationship.
Yeah, so I'm going to introduce myself and I'm here to help you. I know you're scared in here. I know that your feelings are, not controllable at this point. I'm here to help you. Okay. Then as I'm kind of developing rapport with this patient, I'm kind of talking to them, then we're going to set up a therapeutic milieu. What is a therapeutic milieu? Have you ever been to summer camp? Okay, so it's like orientation to summer camp. A therapeutic milieu is saying like, this is the room you're going to stay in. This is the bed you're going to sleep in. I'm going to show you where the cafeteria is. I'm going to show you where you can get snacks and drinks. This is your roommate. So you're kind of orienting them to their environment so that they feel safe. This is your spot. This is your place that you can put your things. Okay. This is where I'll be standing or I'll be if you need something from me. So you're kind of just setting up this place for them. Okay, and making them feel safe in this new environment. Okay, and that's when you're going to set up safety as well. Okay, so this is your bed. You're allowed to have this and this. You're not allowed to have this. We need to change you into different clothing. Okay, so if they have like a belt. Okay, and I've seen practice questions like a patient in mania has been in mania for months, now is in delirious mania, has been admitted. Okay, the patient has lost 20 pounds over the last month. And so she says, oh, can I keep my belt because my pants are falling off and I don't want to be embarrassed? No, because they will hang themselves with the belt. Okay, so you'll have to think about stuff like that. You don't know.
So you have to treat them like they're suicidal?
Every patient that comes in for psych gets treated as if they're suicidal.
Oh, really? Oh.
Yeah, so even if they're not actively suicidal, no matter what you're admitted for, it's safety and making sure that they don't have anything that can harm themselves.
Okay.
All right, then after that, we're going to do a physical assessment. I cannot stress this enough. We will always treat medical before psych because you can die from medical things. You can't necessarily die from psych things. You understand what I'm saying? So you will always treat the medical before the psych, because a lot of times if we treat the medical, that can subside some of the psych symptoms. Like if a patient comes in this delirious mania stage 3, right, and they are dehydrated, they are malnourished, I cannot treat your brain until I treat your body. It's Maslow's, right? I have got to treat the physical things before I start treating the psychological things. We're immediately going to implement seizure precautions because this patient is so sped up that they can have a seizure. Okay. As far as medications, we're going to start them on meds, but remember all psych meds take some time to work.
Yes.
Okay. Lithium takes a minimum of how many days to start working?
A month?
7 to 14 days. Lithium is 7 to 14 days. It's very important that y'all know when psych meds start to work because you have certain nursing care that you have to do before the meds kick in. Okay. So number 1 is lithium. Let's do a crash course on lithium, shall we? All right. What are your 2 keywords for lithium?
Brain.
Sodium.
Salt and kidneys. Salt and kidneys. Lithium keywords. Salt and kidneys. Okay. So lithium binds to
Salt.
in order to be excreted. So lithium binds to salt in order to be excreted. So if they don't have adequate salt, then they're going to go into
Toxic.
lithium toxicity. Right. What is a normal level of lithium?
0.8
to 1.2, which is the same as
creatinine and digoxin.
creatinine and digoxin. Very good. Okay. And so you have to make sure they have adequate salt. You're not going to say have a high salt diet. You will choose adequate salts. Adequate salts. Okay. All right. We need to bring this patient
down.
So we are going to give them anti-seizure meds because those cause severe CNS depression. Okay. We are going to give them benzos. What do your benzos end in? Pamorlam. And what do they do? Bring you down. You with me?
Yes.
Okay. So lithium is the drug of choice, but that is going to take some time. So in the meantime, we can give the anticonvulsants, the benzos, which work rapid. Okay. All right. Nutrition for mania is often on exams. You need high-calorie portable foods. They are not going to be able to sit down and eat a steak and potatoes. They are on the move 100% of the time until the lithium kicks in or until we get these anticonvulsants and benzos high enough in their body. So it's got to be something that they're able to move with. They're constantly pacing. They're constantly moving. Okay. So what are some things that you could choose?
Portable foods. So
Portable
like
foods. But they have to be high calorie.
Mashed potatoes.
That's not portable.
Like nachos.
That's not portable.
Or chips.
Yeah. How are they going to be eaten like this?
uh,
No, they're running.
Fries.
Hamburger. Peanut butter protein shake.
How are they gonna run like that?
They're just holding the hamburger and running. Okay. You'll choose high calorie shakes that sound disgusting, like a peanut butter chocolate milkshake. Yep. We running and we drinking. Okay. So it's got to meet 2 criteria. It has to be easily portable, and it has to be high cal.
Do
You
they
with me?
For the sleep, or do they already
We
get
will.
sleepy with the benzos?
They will get sleepy, but our goal is only I think you said this before. Goal is to sleep for 4 hours tonight.
Oh,
Okay. So we'll give you some anticonvulsants or benzos to do that.
Enforce naps? I know normally we don't, but with that, do we?
You can try to take a nap if they want to, but they probably won't be able to. They're going to be up all day long, and then our goal usually for the first couple of maybe the first week would be to sleep 4 hours at night. Okay. All right, so goal number 1 for our bipolar patients is medication compliance, because what I tell you about their meds.
It takes them to high, so
they don't want to take their meds because they don't want to come out of the high. The high feels good. Now, what happens if you go to give your acute mania patient their lithium and they say, nope, not taking that?
It's up to them, so you can't force.
You cannot force them to take it.
So you say, okay.
You can say, we would really encourage you to take the medication because it will make you feel better over time.
Yeah.
But you have the right to refuse. So if they refuse, you cannot force them to take it.
Okay.
So what if they just keep refusing
Then they stay in the hospital.
Oh my gosh.
Yeah.
Ridiculous.
So number 2 is to prevent a relapse. And how do we prevent a relapse?
Low stimulation.
Medication compliance. We need these patients on their meds. Okay, so in order to the only way we're going to do that is to stable them out with a mood stabilizer like Lithium. Lithium is a mood stabilizer. Do you understand the basics of mania?
Yes.
All right, now let's go to depression.
If they had too high of a salt diet, that would make the lithium not work.
Correct.
Right? Okay.
Correct. But it's very hard to have too high of a salt diet. But choosing more, that's what I'm saying, like hamburger is good because it's real salty and you can add different things onto. You can add cheese, mayonnaise to make it really high calorie, super easy. Okay. Or cheeseburger or whatever. And the shakes are good because they're very high calorie, high fat. Okay. And you don't have to drink that much of them. I wish they weren't because yum. All right. Now let's go to what their depression looks like. Okay. So one day they may just flip and now they can barely get out of bed. The depression can become so severe that they have difficulty even making decisions as small as what am I going to wear today? So it may be if they come in this depression of bipolar that you have to pick out their clothes, that you have to dress them, at least until their medications kick in. Okay. And for depression meds, how long do those take to kick in?
2 weeks.
4 weeks, 4 to 6 weeks usually. So this patient with depression may be in the hospital for a very long time. You with me?
Yes.
All right. Patients with depression go one of two ways. They either sleep all the time or they can't sleep at all, but they still can't get out of bed. Okay. They may become so slowed down that their speaking even becomes more slow because their brain just cannot process fast enough. It is very hard for them to concentrate, to have a conversation with you. They have anergia. What's anergia? Low energy. And anhedonia is a big one. What does that mean?
They don't find pleasure in things that they normally do.
So you're going to ask them, what are your hobbies? What kind of things do you enjoy doing? And they may tell you, but they say, I haven't done that in a long time. They cannot get out of bed when they first come in, and they cannot perform ADLs. So at the beginning, you will perform the ADLs for them. One of your goals is to get them to do it themselves. All right. So what does their affect look like when you assess them? They may call it a blunted affect. Blunted just means like
Flat affect.
Yeah. Or they may call it restricted, so they don't have a lot of animation, right? It's just kind of the same. They may even have psychomotor retardation. What does that mean? Psycho,
Psych.
brain, motor.
Movement.
So because of your brain, your movement, what does retardation mean?
Like slow. very
Slowed.
slow.
So you may say, oh, here's your pill. You're gonna take your pill today.
Damn.
And you have to be very patient because it can be very frustrating. You cannot hurry them. There's no way to do it. Their hygiene is usually very poor. How come?
They don't feel like
take care of
doing
themselves.
anything.
It would take forever and they don't care, right? They may at this point have suicidal ideations. Okay. You may also see physical mutilation like cutting. Okay. They will usually complain of pain, but they can't localize it. So if you'll say like, hey, you're doing your normal assessment. Can you rate your pain? 7 out of 10. Where does it hurt? Right. Because we're doing our PQRST or whatever, right?
Yeah.
It just hurts. Can you tell me where? It just hurts. Okay. So their body actually, they're in so much pain up here that their body is manifesting as physical pain. Okay. We will assess their appetite because most of the time they don't have one. So we'll need to do a daily weight and make sure they're not getting dehydrated or malnourished. And it may be that for the first couple of days you have to feed the patient.
So both of these, they don't really eat much, right?
Mm-mm. Okay. Treatments that we can do to help them with the depression. They can do individual psychotherapy. Group therapy is helpful too. Now, family therapy, very important. For all of these, family therapy are going to be important because you can't manage a psych illness on your own, right? You need somebody caring for you because what were the two biggest things that can get us out of a psych episode? Social support and coping mechanisms. So they will learn coping mechanisms in the individual psychotherapy and the group therapy, right? Yeah. And then we're getting our social support all up and moving in the family therapy. Okay. You will also do cognitive therapy. What was cognitive therapy or cognitive behavioral therapy? Changing your thoughts so that it changes your behavior. Okay? And we will do family-focused psychoeducation. What does that mean?
Like you're teaching the family as well how to help with the
You're teaching the family and the patient, here's what she needs. Are you willing to help with what she needs? Okay? We may also do ECT therapy. Do you know what that is?
Electroconvulsive.
Electroconvulsive therapy. They will tase your brain and hope that we just kind of tase you out of it. And we're going to talk way more about ACT at some point because I know I did a handout on it. All right. Do you understand the basics of bipolar and kind of have an idea what this looks like?
Mm-hmm.
All right.
So is there